will hear from Dr. Lauren Eggert from Pulmonology. And Dr. Eggert will be talking about how respiratory symptoms and manifestations in long COVID can be diagnosed and managed.
Hi, everyone. Thank you for being here this afternoon. It is my pleasure today to talk to you about post-COVID pulmonary symptoms and management. So what we're going to talk about today, first we'll talk about the most common pulmonary symptoms associated with long COVID. Then we'll talk a little bit about the most common post-COVID lung pathologies, then some of the extrapulmonary causes of breathlessness seen in long COVID. I'll go through a basic diagnostic workup for post-COVID patients presenting to your clinic with respiratory complaints, then some of the management options, depending on what the diagnosis is. So here is a systematic review and meta-analysis that was from, I think, about a year ago, looking at the most common post-COVID symptoms in non-hospitalized and hospitalized patients. Here I present to you the non-hospitalized patients, which is the majority of patients. And as you can see, breathlessness or dyspnea tends to be the second most commonly reported long COVID symptom, only second to fatigue and weakness. Which I think for those of us who see these patients in practice can tell you that fits very well with what we see. About 20%, as you can see here, patients with long COVID symptoms, one of them is shortness of breath. Other common respiratory symptoms that we see in post-COVID patients are cough and chest pain and tightness, although these tend to be a much smaller number of patients than those who present with shortness of breath. So this takes us to the question of what is this symptom that patients are reporting? What is breathlessness? It's not as easy as you may think. It is quite a complex symptom, and it definitely does not necessarily correlate with lung function. I have to say, in my practice, the vast majority of patients with long COVID shortness of breath have completely normal lung function testing and imaging. And then, one of the things we have to realize is that the perception of breathlessness is affected by many external factors. There's a lot of anxiety, possibly depression, or other, psychosomatic things that may go into it, previous experiences of breathlessness, and it's definitely modified by a patient's level of physical conditioning and their activity level pre-COVID. So let's start now talking about some of the pulmonary complications of COVID-19 infection. And I want to preface this by saying many of these complications were much more commonly seen during the first year or two of the pandemic, with the first more virulent variants of the virus when patients were getting really sick and hospitalized. So really the pandemic has really, changed, and the pulmonary complaints and things that we're seeing have really changed. But going back to the beginning of the pandemic, we were seeing a lot of patients get really sick with acute COVID infection. As you can see here, this is kind of a longitudinal assessment that was published showing the different chest CT findings and pulmonary function in relation to symptoms in patients who had COVID-19. These images, CT images here on the left, are a really nice depiction of very common findings that we see. When the patients initially present, as you can see in this image that says day 23 on the left, it's really that very diffuse ground glass, sometimes more peripheral. Here you see some more subpleural and peripheral consolidations. Again, very classic for, the first wave of the pandemic, acute COVID in the lungs. Then, as you can see here, what we again see in practice is over time, most patients get better. At 6 months, you can see already by 6 months, almost all of that ground glass is gone. Then at 12 months, it's even better. And then by 2 years, things really stabilize, but they really never go back to normal. What they're pointing to here with the arrow is some residual, like subpleural reticulation, maybe even they're calling it honeycombing, but it's a little small to tell. So in this study, they looked at 144 patients who had recovered from severe COVID infection, followed them out with 2 years with pulmonary function testing and CT imaging. And again, as they saw over time, these interstitial lung abnormalities, these, abnormal findings decreased and pulmonary function improved. But many patients did not fully go back to normal. And it was more common that patients who had these residual abnormalities had more respiratory symptoms. Also tended to have lower diffusing capacity on their pulmonary function testing, even though the rest may go back to quite normal. Another complication that was much more common in the beginning of the pandemic were pulmonary emboli and microvascular thrombi. Like many conditions that we know about of acute illness, acute COVID infection causes this severe inflammatory reaction, endothelial dysfunction, hypercoagulability, which predisposes to pulmonary emboli. And even after one recovers from acute COVID, that prothrombotic state can persist for up to 2 months. From earlier in the pandemic, there were reported rates of 0.9 to 8% of patients hospitalized with COVID were found to have PE. And even in those without PE by found on traditional imaging studies looking for PE like a CTA or VQ scan, research imaging like radio-labeled xenon MRI and others have shown some, smaller, more subtle alveolar gas transfer and perfusion abnormalities that may relate or be due to more peripheral or microvascular thrombi in COVID infection. So what does this mean? Especially for us seeing patients now with long COVID and shortness of breath. Well, I guess the one thing would be to think of is to, maintain a low threshold to think about CTEPH or chronic thromboembolic pulmonary hypertension. This is pretty uncommon, develops in a small percent of patients after a primary pulmonary embolism. So far, there hasn't been reported a big uptick in the number of patients being diagnosed with CTEPH, but it's still pretty early and doesn't mean this, isn't possible and something to look for. And now, fibrosis, blood clots, more to do with earlier in the pandemic, sicker patients. Now, what we're seeing a lot more with more recent waves of the virus or more recent variants is more post-COVID obstructive lung disease and asthma. This is something I had been seeing a lot in my post-COVID clinic, but recently now we have some evidence that this may actually be a real phenomenon. So this is a study out of Korea where they looked at the new onset obstructive lung disease after COVID infection. So they had 3 cohorts, those with COVID-19, severe and non-severe, and matched controls. And they found, as you can see here on this bottom table, that there was a little over a 2% hazard ratio, like 2 times more likely for patients who had COVID to develop new onset obstructive lung disease versus matched controls. And again, here is another figure showing that same thing. The red line are those with COVID and the new who had COVID and new diagnoses of asthma or obstructive lung disease, which early on separates from those without COVID and continues to increase and remain separate from the non-COVID patients and found to be significant. So those are the main pulmonary causes of dyspnea in long COVID patients, residual fibrotic abnormalities, potentially CTEPH, and then new onset obstructive lung disease. But a lot of the causes of shortness of breath in post-COVID patients are extrapulmonary, not related to the lungs. One of the biggest ones is deconditioning. Patients get sick with COVID, they're in bed for a week or two, and it can be really hard to get back to their previous level of conditioning. Patients lose muscle mass when they're sick. That's goes along with frailty too. And that can be a major cause of shortness of breath and, increase the patient's perception of shortness of breath. There are cardiac causes, which I will not get into that much because you're going to get another lecture on cardiology and long COVID today. A significant amount of patients with shortness of breath also it's due to the syndrome they have of ME/CFS or myalgic encephalitis, chronic fatigue syndrome. A study out of Stanford showed that about 50% of long COVID patients meet criteria for this syndrome. And many of these patients have shortness of breath. POTS, or postural orthostatic tachycardia syndrome, or which involves autonomic dysfunction, can make people feel short of breath, especially when their heart is racing. And maybe there is just some other undiagnosed or unknown sequelae of COVID-19 infection or other post-viral symptom that's really contributing or causing shortness of breath in some of these patients that we just haven't figured out yet. So when I'm seeing a post-COVID patient in clinic who's complaining of shortness of breath, this is kind of the basic workup I do, the first 4 things here. Everybody gets a full routine PFT, look with spirometry and bronchodilator response to look for any signs of obstructive lung disease or asthma. Everybody gets full lung volumes, looking for restrictive lung disease and a diffusing capacity to see if there's any abnormalities there that may suggest pulmonary hypertension or some fibrotic abnormality. Everybody gets basic labs, including CBC, looking for anemia, D-dimer and inflammatory markers, kind of as a marker of inflammation, TSH, which can cause, shortness of breath and fatigue. Everybody gets a 2-view chest x-ray just to make sure there's no obvious abnormalities. Chest x-ray is obviously 2D and fairly insensitive for small findings, but it's a nice, kind of screening tool for patients with shortness of breath. Also, we do many questionnaires asking about other associated MECFS symptoms and kind of quality of life and, how patients are, functioning and how their shortness of breath is impacting their functioning. Depending on the results of, the patient's history and results from these initial testing, I do definitely consider and frequently get a high resolution CAT scan if there's any PFT abnormalities, echocardiogram if there's anything suggestive of a possible cardiac abnormality, anything that's suggestive of POTS. I will do some basic autonomic screening with blood pressure and heart rate testing, supine and standing in my office. And then possibly refer for additional testing. And then the other thing I do a lot of is CPET testing, and we'll talk about that next. So what is CPET testing? So CPET is cardiopulmonary exercise testing, also referred to as VO2 testing. It's kind of this specialized stress test or exercise test that can be done either on a bicycle or cycle ergometer or on a treadmill. And basically, while the patient exercises and we get information on both the heart and the lungs response to exercise, kind of can see if there really is a true impairment to exercise. And then if there is, whether it's caused by the heart, the lungs, or something else. So this can be really helpful for patients who have shortness of breath on exertion that we really can't define. So I want to show you, this is a study looking at CPET in post-COVID patients. This is a study from Norway where they looked sequentially at COVID patients discharged from 5 large Norwegian hospitals. It was about 156 patients in total. All of these patients got a CPET 3 months after discharge from the hospital. And patients all did the MMRC, which is a symptom scale commonly used in COPD that asks about patients' functional level and breathlessness. For instance, MMRC of 2 is, can you walk, as far or as much as people of your same age on level ground before you get short of breath? And then this was compared to a reference population. And what you can see here on the right is the table 3 comparing the variables in patients post-COVID who had dyspnea. So MMRC scores of 1 to 4, or those who didn't, an MMRC of 0. And notably, the BMI was statistically significantly higher in those with respiratory symptoms. But other things to note is that the peak VO2, which is the your VO2 max or your exercise capacity, was 31% lower in patients with shortness of breath, which does indicate a true exercise problem with exercise and exercise limitation. But if you look in these patients in both groups, they had a totally normal breathing reserve. So it was not a true pulmonary process that we could tell leading to this exercise limitation. What was abnormal in these patients tended to be their VE-VCO2 slope, which is just a measure of gas exchange, can be seen with abnormal breathing or other kind of oxygen extraction issues. And so kind of the takeaway from this paper was that oxygen uptake was reduced in 1/3 of participants 3 months after hospitalization for COVID, but the most common exercise limitation was deconditioning and not cardiac or not pulmonary. But second was a circulatory limitation, which still was more common than a ventilatory or pulmonary limitation. So pulmonary limitation was kind of the least common actual exercise limitation in this study. And then more recently in JAMA Network Open, there was a systematic review and meta-analysis in CPET testing in long COVID. This included 38 studies with over 2,000 patients, and they found something similar, that exercise capacity was definitely reduced in patients with symptoms of long COVID. And again, the most common reason was deconditioning. They also found autonomic dysfunction, either due to dysfunctional breathing, chronotropic incompetence, or a mitochondrial and or muscular pathology involving peripheral oxygen extraction were also possibilities. But again, nowhere in here do you really see ventilatory limitation or problems with breathing reserve. So again, pulmonary issues do not seem to be the main issue causing reduced exercise capacity and dyspnea in the most post-COVID patients who undergo CPET testing. So how do we manage these pulmonary complications and these symptoms in our long COVID patients? Well, obviously, if there's a real problem, if there's reactive airways disease that you diagnose, you can treat along the asthma pathway. For ILD, you can refer to a specialist for them to consider antifibrotics. But again, this is very uncommon. If you're concerned about CTEPH in a patient who had a PE, obtain an echo and specialist referral to a pulmonary hypertension center. And so for patients with new onset asthma post-COVID, I treat them the exact same way I treat any other asthma patient. I kind of follow GINA guidelines. And so for most patients, that means as needed ICS formoterol, which is the new term is air therapy or anti-inflammatory reliever therapy. And then for the more symptomatic patients, you can use a daily maintenance therapy with an inhaled corticosteroid and a long-acting beta agonist. How do we treat the extrapulmonary causes of dyspnea, which as I've mentioned, seem to be more common and not necessarily related to the lungs? This is a little trickier. For deconditioning, there's great evidence for pulmonary rehab. For dysfunctional breathing, pulmonary rehab or inspiratory muscle training can be helpful. For cardiac causes, again, because I'm a pulmonologist, I'll say refer to a cardiologist. For MECFS, specialist referral, long COVID centers, we have our wonderful post-COVID clinic here that I send a ton of patients to. We're trying a lot of off-label therapies and there's clinical trials. For POTS, again, specialist referral to your friendly neighborhood autonomic neurologist can be really helpful. And unfortunately, for suspected mitochondrial myopathies or peripheral extraction issues, more research is needed. You don't really know what kind of therapy, there's no therapies right now available for that kind of problem. So what is pulmonary rehab? So pulmonary rehab, I like to say, is like physical therapy for the lungs. It's generally an 8 to 12-week program, which has 3 main parts: supervised exercise program to improve conditioning, breathing techniques and teaching of how to breathing exercises, pursed-lip breathing, how to maintain energy, and then a big education component with things on nutrition and other important subjects. Pulmonary rehab has excellent data for benefit in many chronic lung diseases. And there's been a lot of study looking at pulmonary rehab in post-COVID patients. Most recently, a systematic review and meta-analysis looked at the efficacy of pulmonary rehab in post-COVID patients. It included 11 studies with over 600 participants. And in all the studies, in each individual study, there it showed that pulmonary rehab improved dyspnea, physical functioning, and quality of life. The pooled data, due to the heterogeneity between the studies, wasn't as robust, but the subgroup analysis did show improvement in all included outcomes. In my personal opinion, I mean, pulmonary rehab has really great data in so many lung diseases we treat. There's zero adverse events. So, the benefit to risk profile is really, really high. And I really recommend pulmonary rehab for appropriate patients with post-COVID shortness of breath. Something that there's a little bit of evidence on, but again, very, potential benefit, but very low risk, is inspiratory muscle training. There's some evidence for use of breathing exercises like Buteyko breathing in asthma and pursed lip breathing in COPD. In one study, they looked at 281 adults, average age 47, mostly female, recovering from COVID-19 infection. And they randomized them to do some either inspiratory muscle training or usual care. And they did find that inspiratory muscle training in this study led to a reduction in shortness of breath, although overall health-related quality of life was unchanged. And patients did actually improve their maximal inspiratory pressure in this study. So the authors kind of concluded that breathing exercises are low risk, definitely, and might be valuable for people with breathlessness after COVID-19. So, have been proposed by the WHO for potential management of this condition. And again, I sometimes use them. I think it's a nice adjunct. Again, potential benefit, very low risk. So in conclusion, shortness of breath is one of the most reported long COVID symptoms, often number 2, just to weakness. During the early part of the pandemic, multiple lung pathologies, including interstitial lung abnormalities and pulmonary emboli, were seen. And we're still seeing some of the residual of that. But now with newer variants, obstructive lung disease, either new onset or sometimes even worsening of pre-existing obstructive lung disease has been more common. But nonetheless, most cases of breathlessness in long COVID are due to extrapulmonary causes. Most commonly in CPAT studies, it is due to deconditioning. The workup and evaluation for a patient with post-COVID shortness of breath should involve evaluating for and ruling out the most common causes of shortness of breath with imaging, pulmonary function testing, and strongly consider CPAT exercise testing. Management of shortness of breath post-COVID should be directed at the underlying cause. And for patients with shortness of breath without a clear cause, care is mostly supportive, and pulmonary rehab can definitely be very helpful for many patients with a very low risk profile. Thank you all for your time.
Thank you so much, Dr. Eggert. And next, we will have a talk about sleep issues and long COVID from Dr. Oliver Sumping from sleep medicine. And specifically, we'll be talking about hypersomnolence.